Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. It's of a patient who attended today. It was a young girl, aged 8. She previously attended the clinic 2 years ago, so she does suffer from chronic earwax impaction. Her symptoms were obviously reduced hearing, itchiness in the ears, and also very painful ears. So she was experiencing earache, what we call otalgia. Now, one of the reasons why this poor young girl gets chronic wax impaction is to do with the shape of her ear canals, I feel. Now, being a child, obviously the ear canal is a bit narrow, but that's not the sole reason, because most children's ears are narrow and small, and if that was a justification, then every child in the world would have an earwax problem. But we know that's not the case. With this particular child, the ear canal is quite bendy, but also as we enter the ear canal, there's like a little a trench right near the entrance. So it goes down and it goes back up again. And I think that's where the wax is getting trapped. So this wax and dead skin is trying to migrate out of the ear. But as it approaches near the entrance, in this little divot, if you like, it gets trapped and you get a build-up behind it. Now, yes, the patient's ear is very narrow as well, which made it a bit more tricky. And it is also bendy as well, which also added to the complexity. But I've seen many children who had narrow, bendy ears, and it's not always the case that they've got wax build-up. They also have got a lot of keratin. You'll see that a bit later on as we remove the outer lateral piece of wax. Now, the patient had been using some olive oil drops for a few days. That did soften the outer part of the earwax, but as you'll see as you continue to watching, the oil didn't really penetrate deep in the ear, and the wax was very hard, encrusted. And you'll just see, when we took it out, the child actually held it in her hand. I was just really surprised by how sharp it was, like a shard of glass. So I've used a bit of suction, managed to remove some of the lateral bit, but you see this is a bit softer, gooier. The drops had penetrated this. I'm just using an ear hook and a Jobson horn. So I think initially I used a Jobson horn. A Jobson horn is like a hollow spoon, we can call it an ear curette as well. And it's used to scoop out softer types of wax. You can sometimes remove hard wax with a Jobson horn, but typically it's designed for soft, more fudge type wax. Because the patient's ear canal was really narrow, I couldn't get the Jobson horn any further, deeper in the ear. So there was a bit of a gap there. So I used an ear hook, I managed to glide in, pulled it out. I've just put some olive oil drops now, and you can see this wax is right, as we're bringing it forward, the entrance is really narrow and it's getting trapped. So as we're putting the wax through out of the ear, it's dissecting the wax from the main body of the wax. You see there's a lot of keratin there on the outside, that glossy, you can see on the left-hand side, that's dead skin, and that's enveloped itself around the plug of wax. The suction probe just about, I can get it into the ear. Now, you may have noticed I'm coughing a bit again. I've had this on and off for a month or two, and it's just I'm just probably talking too much with my patients and also videos. So so I know a few of you have been concerned. I have seen a doctor. It's just vocal cord rest, and I do. If you've watched my last, I don't know, videos for the last couple of weeks, the cough's gone, but I could feel it. It's just when I'm talking, it's just a bit sore. So I should really be on vocal cord rest, but in the job I am, it's very difficult. But otherwise, I'm fit and well, so don't worry. So it just getting the suction probe. This is a full Zollner suction probe. A fine end, it's not going to be powerful enough. It's quite a dense consistency of wax. It's really heavy and thick. I'm just really trying to tug it through. Bless her. If you watch again till the end of the video, you'll see all the wax on the tissue. There's a huge amount of wax. I'm just using a hook. I'm just trying to hook it in and over the top of this plug of wax. Now, we're quite lateral, so we're okay making contact at the canal wall on the lateral part, the cartilaginous part, but we don't want to be making contact with the bony part of the ear canal within the hook, because it'll be very uncomfortable for the child. And there's some more wax that's kind of oxidized. You see, every time we're bringing this wax through and out of the ear canal, it's kind of detaching itself from the main body, and we have to go back in. And it just keeps coming. It was quite shocking, actually, how much wax was inside the ear, especially considering how small and narrow it was. You can just about fit the Zollner suction probe into the ear. There's not much give way there. And there's that bending. On the right hand side, you can see the ear canal, it bends to the right. So that's the second bend. She had quite a prominent second bend. So yeah, that again can be one of the reasons why the patient is getting a chronic wax infection. Hopefully, as she gets older and the ear canal gets longer and gets wider, she may not have the same issue. So this is more of the harder core of the wax now. This is the wax which is right up against the eardrum. So it's darker, it's been there for longer, it's oxidized. You can see the ear canal kind of goes down, and there's a kind of a vicious bend to the right. And I think it's that bend going down. I mean, so the trajectory of the ear canal, it's going down, which most people's ears do, and they all come back up. But I think for this child, the trajectory going down is quite steep. So the wax has to almost fight against gravity to come out of the ear, per se. So I'm just using a hook, just trying to prise this. Now this is all the waxy, all the crusted, harder shards of wax. So with this, when I held it in the glove afterwards, it was really sharp around the edge. So you can imagine it can be quite uncomfortable for the patient. And that's probably the cause of her irritation. She mentioned she gets an itchy ear and she's been scratching it, or trying to scratch it, but obviously getting into the ear is difficult, and that's going to be pushing the wax in. So we've really got a tremendous amount of wax out. There's still a lot in there. So I've advised the patient and the parents. So the last time she came, it was 2 years ago, so that was age 6. So it's been 2 years since, and I've just said, look, just come every year. Even if it's not fully booked, this is a preventative measure. We don't want it to get this bad. Treating children is really difficult in the first instance. We require the patient to stay still during the procedure. We've got 2 instruments in the ear, and if they're not still, we can cause a bit of trauma and discomfort to the patient. Children are naturally less, well, I don't speak for all children, some children are really, really great, and this patient is really still as well. But the majority of children, they can move a lot. I've got a lot of experience with children now. Not everyone treats children. It is a very specialised thing. There's not many people that I know actually do paediatric earwax removal. And I have no age limit. As long as the child's still, the youngest patient I've treated is aged 1, believe it or not. But it is a bit more tricky and complex. So I'd just advise the parents, look, just come more regularly. We don't want it to be this difficult all the time. So this is this deeper piece of wax, and I'm just using a hook because it was really crusted. I'm trying to lift it off the canal, but it was, again, there's not much space to work in the ear canal because it's really narrow. So I did loosen it from the posterior canal wall. I'm just going to go back in with a suction probe, I believe. Just see how dry it is there. You can just see the eardrum to the right. You can see the top part of the hammer bone. I'm just about managed to get my suction probe in. So I had to really stretch the patient's ear. When the wax is quite dry like this, it's difficult to, firstly, obtain a suction grip and then, obtain it, and then secondly, to maintain it. So it's one thing obtaining the suction grip, and then you've got to be careful not to lose it as you pull the suction tube out of the ear, because you can quite easily let go of that wax. So the remaining piece of wax, this is probably the sharpest bit of wax. I am using a fine end here. I'm bringing it to the entrance, but I keep losing the suction grip. So I will eventually get this out with the help of forceps. I'm going to use some forceps and bring it right. So this is right to the entrance now. I think I'm going to just bring it a bit further forward with the fine end suction probe. Just a bit further out. So we know we're near the entrance. Now, one of the things with children, you may have noticed watching a few of my recent videos, I've done loads of children's ears. They've got quite hairy ears, believe it or not. So I think that's kind of surprising me more and more. You can see just how much hairs they are. We normally associate hairy ears with more the elderly male patients, but children also do have quite a lot of hair at the entrance of their ear. You can see that there. So just using some forceps now. So I think we used all the instrumentation there. We used a standard Zollner suction probe. We used a fine end suction probe. There's the patient's eardrum, nice and healthy. I did tympanometry just to make sure there's no catarrh or glue ear behind the eardrum. So we used, so the middle ear is functioning fine, the impedance, the mobility, compliance. There's all the wax that we removed on the tissue. So yeah, so we used a Zollner suction probe, a fine end suction probe, an ear hook, a Jobson horn, and a forceps. I would call it a full house earwax removal. Maybe that's what I'm going to title the video, full house earwax removal. Take care, guys. I'll speak to you soon. Bye.